So good evening, everyone. On behalf of Gravitas Mankind, I, Akriti from marketing team, welcomes you all in today's session of Direction Module Certification course. So now we are going forward with Module 3, that is Management of Vertigo Patients. So now I'll call Dr. Prashant Agrawal, who is Head Medical Affairs, to take the session forward. Thank you.
Thank you, Akriti. And thank you once again to all the audience who have joined us here to the third module of this online module-based certification program, Direction. As you are aware, we are conducting this program under the guidance of Dr. Anirban Vishwas sir, and the speaker is a very famous Dr. M. Ilam Bharti sir. So before we go into the introduction and the actual program, just let me introduce you once again to my company, Mankind Pharma. As you know, Mankind Pharma is currently the #1 company in terms of prescription, and we are the youngest company to achieve the feat of coming into the top 5 of Indian pharmaceutical market. Mankind Pharma was established on a very simple philosophy of serving life. And the 3 pillars which guide us are quality, affordability, and availability. Throughout, after its inception in 1995, throughout this journey till today, we have achieved many milestones, such as we launched our US operations in 2015. We have got our own plant as a US FDA approval in 2019. And we have launched as the first Indian company to develop dydrogesterone in the world in 2020. We are making our feet in research and development as well, and focusing on clinical research endeavor with our force of 600 scientists working in 3 world-class R&D centers. And we are developing our capabilities, and we are pioneering in formulation developments, complex formulations, complex APIs, and we have a dedicated block as well for hormonal products. If we talk about new chemical entities, we are currently working in diabetes segment targeting GPR119, and the molecule currently has entered into the clinical phase of the development. With this, we have also launched DMF grade molecules, DMF grade medicines to our Indian patients. DMF is basically, it's a drug master file. It's basically a file which contains all the information about manufacturing of a drug, the final product, final medicine, which goes to your patient. So it contains about information about manufacturing, processing, packaging, and storage. And along with that, it also contains information of chemistry, stability, purity, impurity profile, packaging, and of course, the current good manufacturing practices status also. This DMF, the Drug Master File products, which basically talks about everything. So if we talk about the US FDA, so they actually communicates about the quality, safety, and efficacy of the drug. These manufacturing facilities, which have a license to produce DMF grade products, they can apply for marketing rights also along with in FDA. These plants maintain highest standards of manufacturing practices to ensure quality and safety of the drug. And it is believed that DMF grade facility products are of highest standards in terms of safety and efficacy. So what do they bring on table? The credibility and confidence, the responsibility, rheology, alacrity assurance, and of course the economics. Because all these DMF grade drugs, they are available on a very lower cost. So you can say your patient will get the same international quality which US or European patients are getting, but at a very lower price, or you can say the Indian price. So the international quality at Indian prices. India is pioneer in when it comes to the filing the DMF grade or the DMF counts by countries. But unfortunately, these DMF grade compounds, the DMF grade products are not available to our Indian patients. So Mankind Pharma has taken this initiative to provide all the products which are available in DMF grade to our Indian patients. And very soon we are going to launch beta histine as well under that, which is the API which has comes from the DMF grade facilities. So we really thank you for your continuous support and encouragement for us, and we really cherish this partnership in care. With this, I once again welcome you all to the third module of this direction program. And now I invite Dr. Anirban Vishwas sir, who is, of course, Director of Neurology Institute of Neurosciences and the main guide, the main force behind developing this program for all of you across India. He has been pioneer in establishing the medical discipline of neurology in India and the neighboring countries. He is also well known for his contribution to the development and popularization of medical audiology and neurology among doctors in India and abroad. He has been past president of the Association of Otolaryngologists of India and Neurological and Equilibrometric Society of India. He is ex-editor of the Indian Journal of Otolaryngology and Head and Neck Surgery. He has been ex-vice president of International Neurological and Equilibrometric Society and currently editor of Annals of Otology and Neurology, which is the official scientific publication of the Indian Society of Otology. He has received many awards throughout his career. To name a few, he is recipient of Taito Clausen Award and Frenzel Sakata Award. Also takes honorary lectures for ENT postgraduate students at IPG-MER and SSKM hospitals of Kolkata. So with this, I invite Dr. Anirban Vishwas sir to initiate the session and, of course, welcome our speaker, Dr. Ilam Bharti sir. Sir, Dr. Anirban sir, over to you.
Yes. So it's good afternoon, late good afternoon to everybody. And we are first of all thankful to Mankind Pharma for giving us this opportunity of spreading neurology in a ethical and a rational way such that young practitioners can handle patients of vertigo in the best way possible and as per guidelines prescribed by the different societies and in the most ethical and rational way that is possible. Just like they have come out with this organization, Mankind Pharma has come out with a very standardized product, which is this DMF grade of medicines. Similarly, for us also as practitioners, it is our duty to ensure that we maintain the best standards of practice. And to maintain the best standards of practice, it is mandatory that we stick to ethical and rational practice. You have to know the inside out of the drugs that you are giving and what benefit is the drug giving to the patient, and if at all any harm is being induced, then what is the harm that this drug is inducing. And on the basis of it, you have to take a call on whether to use the drug or not to use the drug. We have to remember that the damage caused by the drug should never be more than the damage caused by the disease itself. So this is where the most important thing comes in. And in vertigo, the problem is that this is possibly the only part of medical discipline where people don't treat the underlying disease and people treat the symptom only. Throughout our student days, we have been taught that find out the cause of the disease and treat the underlying cause of the disease. This happens everywhere. If you have a patient, a fever comes to you, you may give a symptomatic treatment with paracetamol for 2-3 days. But after that, you'll try to find out the cause of the fever and treat the fever. That unfortunately does not happen with vertigo. And in vertigo, what is necessary is that we have to be very, very rational in treating the patient, finding out the underlying cause that is causing the disorder, and then treating the underlying cause. And that is why we are doing this series of presentations, and we have done 2 modules already. One was on history taking, one was on clinical examination, and this is the third one, which is on therapy. And this presentation is limited to the drug therapy only. We have with us a very renowned and a star ENT practitioner in South India, Dr. Ilam Bharti, who is also the secretary of our Indian Society of Otology. He runs our society so well, and he is anybody in South India would be knowing Dr. Ilam Bharati in a very, very big way, and I do not need to introduce him. But then anyway, he is a consultant ENT and a surgeon and a plastic surgeon in Chennai, and then he is an executive member of the Indian Society of Otology. He was the treasurer and now he is the secretary. He has performed thousands of mid-ear surgeries, endoscopic sinus surgeries, microlaryngeal surgeries, and has chaired sessions in ENT conferences, both national and at international levels. He conducts a large number of ENT workshops in Chennai and has done it at many other places also. So anyway, let us get back into the topic proper and let Dr. Ilam Bharati take over from here. And his topic of presentation today is drug therapy in vestibular disorders. Okay?
Thank you.
Yes.
Thank you, Biswas sir, for your nice words. At the outset, I thank Mankind Pharma for giving me this opportunity. So I will try to share my screen.
So your screen is visible. So just go to the PPT, sir. Your screen is visible, sir.
Yeah, 1 minute. Again, clicking the PPT.
Yes, sir. It is visible, sir. Just click on the full screen mode, sir.
Yeah, now it is
will
visible. Oh,
yes, sir. It is.
Fine. Okay. Just come to the full screen now.
Yes, sir.
Yeah. So, good evening. So today, the topic that is we are going to discuss is the most important one for the practice point of view for us, for the doctors. But how do we practice the dizziness management? Whether we are doing it in ethical, rational way, we are treating all the patients. That is what we are going to see today. It's not moving. 1 minute.
Sir,
whether it is moving.
sir, please unshare the screen.
Yeah.
And then once again, click on the share screen.
Okay. Okay.
And so then a window will pop up. Then in that window, click on the
Yes.
your PPT, sir. PPT remain open, sir.
Yeah. It is not. I'm not able to unshare it. It's not working. I will just.
Sir, please click on the screen once.
That is why my mouse, I'm just trying to click. It is not seen. One minute.
Okay, I guess sir has logged out. There is some issue with connection, I guess. So, dear viewers, please be with us. There is some technical issue with on Dr. Ilam Bharati's side. So we're just waiting. He's relogin.
Dr. Prashant, so why don't you now tell other people, tell our audience about this scheme in which we are doing it,
Yes,
and
sir.
that we have our things. They can see the presentation later on, which will be put up for them in our website and all. So all these things.
Absolutely, sir. Absolutely.
While Dr. Ilam Bharati gets his slides ready.
So, dear audience, as you are already we are just waiting for Dr. Lambarti sir to rejoin. Meanwhile, I would like to take this opportunity to discuss or to share the very important part about that this content of this module will also be available later on to all the registered doctors for so that they can revisit the content part. Although, of course, the commentary for Dr. Lambarti sirs will not be available because it will be available in this live session only. But the content definitely will be available for you to revisit in the for in this website, which is the direction vertistar.in. Sorry, I just received a call from Dr. Lambarti sir. Actually, his laptop underwent into restarting mode. So it has already now started. So maybe in the next 1 or 2 minutes only, he will be joining. So, dear audience, you can go and visit this website where you can find the content of rest of two modules as well. You can find a quiz on there. For each module wise, there is a separate quiz. So you can go and take that quiz, which is very important for accessing the certification. You can put your queries. I mean, you can put your queries. You can ask your queries in live session as well. But there is an opportunity later on also. If you have some queries, you can put into that website. And of course, you can put your feedbacks as well. And as you know, all the feedbacks are always welcome. You can give us suggestions how what content you would like to see maybe in future, because this program will definitely go on in future as well. So any topics, any content you would like to see in future, please let us know.
Directly click
Sir,
on the
you are
screen.
not visible, sir. Your screen is visible.
So you are hearing my voice now? You are hearing my voice?
Yes, sir.
Yes.
Yes, sir. Your voice is audible.
I will continue. Sorry for the thing. Yeah. So, okay. So I'm just going into the topic proper. So first of all, we have to remember the first and foremost thing in all cases of vertigo and dizziness, the prognosis is generally very good. So we know that most of the peripheral vestibular disorders, they improve spontaneously, and most of the central vestibular diseases, they require central compensation, and so compensation of vestibular tone imbalance occurs. So the first and foremost thing we have to tell them is reassure the patient. The distressing symptom, that is vertigo or dizziness, can be successfully controlled. And the commonly used drugs for this purpose is the group antihistamines or benzodiazepines, antiemetics, and in some cases SSRI and SNRI, etc. So coming to the ethical rational management of dizziness, you have got these following modalities are available. The first is the drug therapy. And the drug therapy you can classify into non-specific symptomatic drug therapy or the specific therapy to treat the underlying disorder. And coming to the maneuvers for the benign positional paroxysmal vertigo. And the physical therapy, it can be a non-specific one or organ-specific one. And finally, you have to do the counseling also for the behavioral therapy, that is the CBT also. So if you see all the modalities of treatment, all the modalities of treatment are okay, but the non-specific symptomatic therapy, though we are using it for a longer duration, that has to be condemned. We have to use it for a very limited, shorter period of time. That is what we are going to see it today. So the objectives of the management of the vertigo is, so provide the symptomatic relief, but whenever we give symptomatic relief anti-vertigo drugs, we have to take care of the inherent ill effects of the anti-vertigo drugs. And naturally, in all cases of vertigo or dizziness, we have to diagnose the cause of the vertigo and treat the cause of the vertigo, rather than simply merely suppress or camouflage the symptom of vertigo. And we always think of treating the comorbidities in all cases of vertigo, because vertigo is a multimodality disease. So we have to always think of comorbidities, and we have to include the treatment of comorbidities also. And finally, we have to think of restoring the deranged balance function by physical therapy, or provide psychological and mental support by reassurance, counseling, as most of such patients are in severe mental distress. So, comorbidities in the vestibular disorders, we have to always think balance disorder patients are not just vertigo or dizziness. They will have irrational behavior, poor concentration, forgetfulness. They have got memory problem. They have got concentration problem and arithmetic and reading problem. So always we have to think of the psychological and emotional disorders associated with the vertigo and dizziness patients. So a holistic management factoring, we have to always consider the psychological and emotional deficits that we have to consider in all cases of dizziness and vertigo. So what is new in today's scenario? Our understanding of vestibular pathology has undergone refinement. So now we know the pathology and the physiology of the vestibular system, and so the morbidity and also the comorbidities of the balance disorder patient is now better understood. The lesion in the vestibular system can be very precisely diagnosed with the pinpoint accuracy, and the nature of pathology and also the site of the lesion easily identifiable. So very specific treatment is available for most or almost all the causes of balance disorders today. So management now involves treating the comorbidities also. The vestibular physiotherapy targeted to specific organs in the vestibular system is now a reality, providing a much better outcome. So virtual reality and also an augmented reality is being used for improving the balance function. So we have to have a holistic, ethical, rational, and evidence-based multimodality management program in when treating all cases of dizziness or vertigo. So the vestibular sedatives in the vertigo management, what is their purpose? They decrease the sensation of head spinning. The common drugs we use are the prochlorperazine, meclizine or dimenhydrinate, and cinnarizine or diazepam, and also beta-histine. So most of these drugs, they decrease the sensation of head spinning. So they provide symptomatic relief by the receptor blockage in the cholinergic pathways, inhibiting the vestibular labyrinth, decreasing the discharge rate in the vestibular nuclei. So they are sedating the central nervous system, and they are also inhibiting the sensory conflicts. So all these processes inhibit the central vestibular compensatory mechanism. But sensory conflicts that increase the vertiginous symptom enhances the compensation. But all these drugs, what they do is they inhibit the sensory conflicts and they delay the vestibular compensatory mechanism. So the outcome of the prolonged use of the vestibular sedatives is poor vestibular compensation, complete balance function is not restored, and also the persistence of imbalance. So what the world believes in today is the vestibular sedatives or the labyrinthine sedatives, they should be used for only for the first 24 hours or at least 1 to 3 days only. So the medically, morally, ethically, and scientifically, it is irrational to continue to prescribe or use the anti-vertigo drugs for an indefinite period, even though this is the common trend in the medical practice. So the role of vestibular suppressants in acute vertigo is definitely it is there, because whenever the patient is symptomatic, so naturally it gives symptomatic relief from vertigo and vomiting. Naturally, it relieves the concomitant mental distress directly or indirectly. It reduces the anxiety and also the mental distress. But you have to always consider the negative effects of the vestibular suppressants when we use. They cause CNS depression. They reduce the vestibular compensation. They inhibit the autonomic nervous system. It does not cure the disease, only partially camouflage the symptoms of the disease. It induces serious adverse effects. So all these negative effects we always think and we have to prescribe the vestibular suppressants. So what the problem with the anti-vertiginous drugs? All such drugs act on the neurotransmitters in the central nervous system. So none are destined for the vestibular system. Hence, all induce multiple systemic side effects. Most act on the autonomic nervous system that control the vital body functions, hence detrimental to the health and induces unwanted morbidity. Most of the drugs jeopardize vestibular compensation and induce CNS depression, hence better or best avoided. Most have serious adverse effects not only on the long-term use, but also on the short-term use. Hence, use to be grossly restricted and avoided. As I told, we have to use it for 1 to 3 days maximum. Some drugs have to be proved to be no better than the placebo. So coming to the problems with the anti-vertigo drugs, the neurotransmitters active in the vestibular system are the acetylcholine, dopamine, serotonin, norepinephrine, GABA, and histamine. So the anti-vertigo drugs are a combo of anticholinergics, antidopaminergic, anti-serotonergics, and drugs modulating GABA, norepinephrine, and histamine receptors or calcium channel blockers. So the problems with the anti-vertiginous drugs, effect of the blocking of the neurotransmission, cholinergic transmission by all the cholinergics. So it will cause sedation, dryness of the mouth, and reduce the secretion by the sweat glands, tachycardia, bronchodilation. So you can see the empty number of adverse effects by using the anticholinergics. Likewise, if these antidopaminergic drugs, the patient can develop Parkinsonism, dystonia, tics, tremors, oculogyric crisis, and serotonergic transmission by anti-serotonergics, constipation, headache, and dizziness, and blocking the calcium channels by calcium channel blockers. Patient may develop lightheadedness, low blood pressure, bradycardia, drowsiness, constipation, pedal edema. So you can see all the complications of all the anticholinergics, antidopaminergics, and anti-serotonergics, and the calcium channel blockers. And what the drugs we use and anti-vertigo drugs are the combination of these. So this is the main thing. Did the dizzy patient tell you, by giving medicine, doctor, take away my vertigo, but give me 10 other morbidities like drowsiness?
Hello, sir. Dear audience, suddenly due to some network issue again, sir has logged out, so he's relogging. Akash, can we mute other participants?
Yes, sir.
Dear all, but just be with us. Sir is joining in a while. Dear all, there is some technical issue. For that, okay, Dr. Bharti sir has just joined once again. So he is here. Sir, you are on mute. Sir, please unmute.
Yeah. So are you hearing me?
Yes, sir.
Yeah. Sorry for the interruption. My laptop suddenly crashed. Yeah.
So sir, on
I will
which
just
slide?
continue. Yeah. I will continue. The comorbidities in the vestibular disorders I have just told. So it is not only you are hearing my voice? Hello, you are
Yes,
hearing
sir.
me?
Yes, sir.
Yeah.
Yes, sir. Your voice is audible.
Yeah, fine. So we should not think of only dizziness and vertigo, and we have to always think of the comorbidities. So next slide. Yeah. The next slide. Yeah. This already we have discussed. Yeah. So this is new scenario also we have already. So this is what we are discussing. So we have to realize, we have to know the holistic, ethical, rational, and evidence-based multimodality management we have to follow in all cases of dizziness and vertigo. So next slide. Yeah, these are all the common drugs we use, but they suppress the central nervous system and also they inhibit the sensory conflicts. Next slide. So next slide. This already we have discussed. Next slide. So next slide. Yeah, next slide. So all these things we have discussed. Next slide. So next slide. Yeah, next slide. So as the next slide, till then we have discussed already. Next slide. Yeah, next slide. So this is what, yeah, previous slide. Yeah. So whenever a dizziness patient comes to us and the patient did not expect or did not tell us that doctor, take away my vertigo, but give me 10 other morbidities like drowsiness, tachycardia, constipation, impotence, Parkinsonism, dystonia, headache, pedal edema, hypotension, and dryness of the mouth. Yeah, this we have to remember when we are treating any patient with dizziness with anti-vertigo drugs. Though we are giving symptomatic relief, we are giving additional adverse effects of the drugs also we have to think of. Next slide. So, do not ever prescribe a vestibular sedative for a longer duration. Only treat, ideally, we have to think of, if at all we are giving symptomatic treatment, it is limited to for 1 to 3 days. Only treat the underlying disease causing the vestibular disorder. Vestibular physiotherapy only will cure all the vestibular disorders, hence try to avoid drugs for treating vertigo. This is one school of thought. One perception is, do not prescribe vestibular sedative. Vestibular physiotherapy only will cure all vestibular disorders. Is this correct? This is also a wrong one. Next slide. So this is also wrong one. Next one. Next one. So the vestibular sedatives are needed to allay the patient's acute morbidity and fear, but must be used with utmost discretion and restraint and never for more than 3 to 5 days, factoring in the adverse effects. Even most drugs used for treating underlying disorders have some adverse effects and warrants judicious use. Hence, sagacious and rational use of drugs is the key to the success of the therapy. Next slide. So there are no untouchables and no wonder drugs in the pharmacotherapy of the vertigo. It is the intellect and the rationality of the treating doctor that matters. Next slide. So prudence and caution is virtue. Paranoia is the vice. Next slide. So treating the specific causes by specific therapies. So if we find out, if come to the diagnosis, then if it is BPPV, we are going to treat the patient with the liberatory manovers. For each canal, it is going to be different. For posterior semicircular canal, the diagnostic test is going to be the Dixon-Hallpike test, and the manover is going to be the Epley's manover or Siemens manover. If it is a lateral semicircular canal pathology, then we are going to do the supine roll test, and the treatment is going to be the either barbecue maneuver or Guffoni maneuver. Likewise, if it is a rare anterior canal means, then the supine hangover test is the test what we are doing, and the treatment may be the Jacobino maneuver. Hello.
Yes, sir, you are
Hello.
audible. Yes, sir.
Yeah, you are hearing me?
Yes, sir.
Yes. So whenever, since I am connecting with cell phone, whenever the call comes, it is going up. So the treating the specific causes, you are hearing me?
Yes, sir. Yes, sir, you are audible.
Yeah. So the BPPV I was telling, and also if you diagnose it is the vestibular migraine, so we are going to treat the patient with the, for the acute attacks, we are going to use the ergotamines or the triptans. And for the prophylaxis, we are going to have empty number of drugs like antidepressants or beta blockers or the topiramate group of drugs like that. And for the vertigo attacks, we have got during the acute attacks, and for the prophylaxis, we have got already, we have enumerated the drugs names. And if it is the P3D vertigo, then there is a role of SSRIs and the SNRIs are the benzodiazepines that are the drugs of choice for the psychogenic vertigo or P3D vertigo. If it is a vestibular neuronitis, then the steroids, definitely the role of steroids is there. Likewise, if it is a Meniere's disease, if you diagnose, then the role of diuretics and also the beta histamine, which is debatable, it is there. But if you diagnose labyrinthitis, we are going to treat the patient with the antibiotics and in some cases antivirals and steroids. If we diagnose vestibular paroxysmia, then the drug of choice is going to be the carbimazepine in the dose of 200 to 600 milligram OD. And if it is the vestibular seizure, we are going to use anti-epileptic drug. Next slide. So if you, next slide. So if you see the causes of vertigo and dizziness, the commonest cause will be the BPPV, which is going to be 26%. The second will be the P3D or psychogenic vertigo, 23%. Third will be the migraine-related, migraine-associated vertigo is 21%. All the other causes like vestibular neuronitis, labyrinthitis, Meniere's disease, other primary otolithic disorders, vestibular seizure, sensory ataxia, bilateral vestibulopathy, central vertigo due to oculomotor and other CNS diseases like extrapyramidal and cerebellar disorders. So all these things, if you take more than 95% of the patients are the vertigo and imbalance, you can arrive at a diagnosis. Next slide. And the specific therapies exist for all of them, and none require long continued non-specific therapy with anti-vertigo drugs. Next slide. So these are all the common drugs we are using for the anti-vertigo, that is for the treatment of vertigo or dizziness. Diamond hydronate, diazepam, prochlorperazine, promethazine, cinnarizine, beta-histine, meclizine, and ginkgo biloba. Next slide. And coming to the first drug, prochlorperazine, which is a very effective drug for providing symptomatic relief in acute vertigo with vegetative symptoms like nausea, and it takes care of the vegetative symptoms like nausea and vomiting also. But it is a mechanism of action of prochlorperazine is an anticholinergic, antihistamine, and antidopaminergic effect. So it has got an adverse effects of anticholinergic, antidopaminergic, and antihistamines all put together. And the commonest adverse effect everybody is worried about it, the extrapyramidal disorders like Parkinsonism. So pharmacologically, it is recommended use is an anti-emetic and anti-migraine drug. Oh. Hello. You are hearing me?
Yes.
Yes, sir. Yeah, yes, sir, you are audible. Hello.
So it is mainly recommended for anti-emetic and anti-migraine drug. So the FDA indication is only for schizophrenia and acute psychotic episodes and chronic mental illness and for nausea and vomiting. And from experience is the most effective drug for the symptomatic relief in acute vertigo. Next slide. So it is effective for symptomatic relief, but with many adverse effects, and that clinicians need to be careful of. Next slide. And FDA indications already told. Next slide. And adverse effects of the prochlorperazine also I told, extrapyramidal symptoms, neuroleptic malignant syndrome, and cheilitis of the lips and tongue, and orthostatic hypotension, and other anticholinergic effects are also. Next slide. So this is the literature is showing for the prochlorperazine. So it is prescribed for a variety of unrelated conditions, including problems with the vertigo and dizziness. And it is the indicated drug for the some other thing. Next slide. So coming to the second drug, the commonly used drug is the cinnarizine. It is also a labyrinthine sedative effect. It hence provides reasonably good relief and symptomatic relief. So it improves the blood supply to the inner ear and also brain by anti-vasoconstrictive effect and also by reducing the slugging of blood in the narrow blood vessels. Next slide. And it has got an anticholinergic and anti-dopaminergic, anti-serotonergic and calcium channel blocking effects. So you put together all the adverse effects of all the four, and it is not an FDA approved drug because of the too many adverse effects. Next slide. And all the four, that is anticholinergic, anti-dopaminergic, calcium channel blocking action, and anti-serotonergic effects. Yeah, next slide. So it is also an effective drug for the symptomatic relief, but with too many adverse effects that clinicians need to be aware of or scared of. Next slide. So when the cinnarizine given, the patients will have this problem of it gives some good symptomatic relief, but the side effects of drowsiness, extrapyramidal symptoms, all these things are there. Next slide. And coming to the next commonly used drug, the most commonly used drug for vertigo is the beta histone. Beta histone, the advantage is it is not a CNS depressant like other drugs. The most prescribed drug in India, recommended for the Meniere's disease and some other therapeutic guidelines. And it is not an anticholinergic drug, and it is an antihistamine drug. So it has got a dual action. It has got an antiemetic effect also. So it is believed to increase the blood supply to the inner ear. So being a histamine analog, it promotes the wakefulness, which indirectly may help in the vestibular compensation. Next slide. So this is the literature evidence is the for the this is coming for the cinnarizine. Next slide. So this is also the adverse effects of flunarizine and cinnarizine. Next slide. So this is also for the adverse effects of cinnarizine. Next slide. Yeah, this is coming to the pharmacology of beta histone. So it is a H3 antagonist. That is it has got a dual action, antagonistic action and agonistic action. That is in the H3 receptors. Next slide. So literature also tells that it can be a vestibular suppressant and it can be a vestibular stimulant. There are conflicting and confusing reports in the literature regarding the beta histone because of its dual action. That is a H1 agonist and H3 antagonistic action. Next slide. But it is one of the mostly wide used drugs in the ENT practice in India. Coming to the next drug is the dimenhydrinate, very effective in acute vertigo with pronounced vegetative symptoms and antiemetic effect, and it is devoid of the extrapyramidal reactions. So conventional antihistaminic with high anticholinergic activity. So it inhibits the spread of disparity vestibular stimulus to centers for vegetative regulation in medulla. Adverse effects, highly sedative. So impairs psychomotor skill, affects the color discrimination, night vision, all these things. Next slide. Coming to the next drug, meclizine, which is effective in acute vertigo with vegetative symptoms. So it has got an antiemetic effect devoid of extrapyramidal reactions. And the pharmacological action is an anticholinergic and antidopaminergic action with concomitant adverse effects. And it is an FDA approved drug and the OTC approved drug for that is for vertigo. So hence this may be safely prescribed, but it is generally underutilized in spite of its safety and efficacy. And this is the only drug that can be safely used in pregnancy. Next slide. And this is the slide just to differentiate the dizziness and the associated psychic disorders like conversion disorder, functional dizziness, and the psychiatric disorders. So next slide. And the vestibular migraine or migraine associated vertigo and Meniere's, there are two drugs are usually recommended. That is the antidepressants like amitriptyline and desvenlafaxine also is widely used in treating the vestibular migraine patients as a prophylactic treatment. Next slide. So coming to the take-home message, so restrict the use of symptom-relieving anti-vertigo drugs to the maximum of 3 to 5 days. And it is mainly used only in acute vertigo. Never prolong the use for more than 5 days. Treat the underlying disorder causing the vertigo rather than camouflage the symptom of vertigo. the underlying pathology and the site of the lesion can be diagnosed very accurately in most of the cases, if not all the patients of vertigo today. So select the drug and its dosage and the duration judiciously. Balanced pharmacotherapy using vestibular suppressants and disease modifying therapy and factoring in both the adverse effects of the drugs as well as the expected patient benefit. So in all cases, we have to assess the benefits and also risk when using this drug. Risk benefit ratio, we have to assess in all the patients. So treat the concomitant psychological and cognitive impairment for a complete recovery and expedite vestibular compensation through organ targeted physical therapy. Holistic multimodality treatment is the solution. Next slide. So holistic, ethical, rational, evidence-based multimodality management rather than a prolonged therapy with vestibular sedatives is the principle of contemporary pharmacotherapy of the vestibular disorders. Thank you. Next slide. Thank you. Thank you. Yeah. Sorry for the hitch I had in my laptop and other things. Yeah.
So, thank you, sir. I know, sir, because of in this technological era, there are few things we are dependent upon technology, and technology can ditch us anytime. So, this is what happened this time. So, we apologize to our all the viewers, and but definitely we are now on track, and we have already listened. I mean, what Dr. Lambarthi just shared. So, I move on to Dr. Anirban Vishwas, sir, for his comments on the Dr. Lambarthi's presentation, sir.
Well, I think it's best to talk about these technological glitches that happen.
Yeah.
You know,
Yes,
in a place where Anil Ambani had been called to give a lecture to young students. There he said that you people are all bothered with 4G and 5G and these things. What matters in life are only the two G's, Pitaji and Mataji. These are the only two G's that matter in life. 3Gs and 4Gs and 5Gs, they will cause more problem in life than anything else. So that is what Anil Ambani said to a group of students who had gone to meet him. So anyway, see, these glitches will happen. You cannot do anything about it. Anyway, fine. So this is the complete presentation from Dr. Ilam Bharti. I believe message has been well communicated that you have to be very careful and conservative with the drugs that you are prescribing. When it comes to vertigo, all these drugs have a lot of negativities. Beta-histine is a safer drug that way. And so it is not so effective in very acute vertigo with vomiting and all. There we would want to prescribe, say, prochlorperazine or say dimenhydrinate or something, but then 1 or 2 doses only. But then this is a safer drug to continue with for a few days. And so that I believe sums it all up. Okay. Sure. I believe there'll be some questions. If some questions have come,
Yes,
then
sir.
Dr.
Yes, sir.
Prashant
Yes,
will
sir.
communicate them to us and
Sir,
we'll take
due
it up.
to definitely. So I request all our audience, of course, you can put your questions on the website. But right now, if you want to ask, please put it in the chat box. So, sir, right now, what I can see, sir, one question is that how long can vinpocetin, piracetam, and ginkgo biloba combination tablet be used? Is it safe to use beta-histine for many months for chronic vertigo?
Sir, you want me to answer, sir?
Yeah, please answer that.
Yeah. Definitely, these are not anti-vertigo drugs. The paracetam is supposed to improve the blood flow to the cochlea and also to the inner ear. So it is not an vertiginous anti-vertigo drugs meant for it. So if I put it in another way, it is not the main drug. It is like a pickle in a meat. So the ginkgo biloba and the piracetam comes like a pickle in a meal. It is not the main meal or the main drug to treat the vertigo. So when you are adding this drug as a third drug or the second drug, not to treat the vertigo, to improve the blood flow to the brain, improve the blood flow to the cochlea, so that it is prescribed for a longer duration. So, but you have to think it is not the main drug to treat the vertigo. It is not a symptomatic treatment, or it is not also comes under the causative treatment. It is a general drug used to improve the blood supply to the cochlea and the brain. Am I correct, sir?
Yeah, of course. See, piracetam and ginkgo biloba are used in treatment of vertigo off and on when there is no other drug to give and you do not have the guts to tell the patient that you do not require anything. So if you have the guts, it's best tell the patient that you do not have anything. Neither piracetam or ginkgo biloba has got anything in them which will prevent vertigo. In fact, when in 1970, when piracetam got FDA approval, it was the approval was as an anti-vertigo drug. But then after that, it lost this thing, and then it is no longer used as an anti-vertigo drug. It increases the blood supply to the brain, as Dr. Ilambarti pointed out. It increases the neural transmission in the brain, and these things. These are very indirect ways of improving the health of the brain. Both ginkgo biloba and this for peripheral vertigo, it has got no role. And in central vertigo, yes, if there is nothing else to give, these drugs are usually given. But then how much is the placebo effect of these and how much these actually benefit the patient is impossible to say.
Yes, sir. Yes, sir.
So, sir, that was the question. So, I thank you, Dr. Lambarti, sir, for, I know with this technical glitch also, he completed and he shared all the information which was there. So, I really thank you, sir, for your support and this talk. And of course, I sincerely thank Dr. Anirban Vishwas, sir, again for his guidance and mentorship for this program. And I thank you all my audience who has been with us during this issue as well. They were there with us and they are still here. So thank you everyone for joining us.
Yeah.
Thank you so much. Thank you.
Thank you for all the audience. My heartfelt apologies. Still, I am feeling very bad because suddenly my laptop crashed, so that this has happened. Sorry for the inconvenience to all. Thank you, Prasant.
Thank you, sir. Thanks.
Yeah. Thank you, sir. Anirban, sir. Thank you.
Yeah. Thank you. Good.
Thank you.
Nice presentation.
ಚಾರ್ಜ್ ಆಗ್ಲ ತೆರೀಲ.
ಅದು ವೈರ್